Welcome to the Basic FESS CD 2. In this CD we are going to be looking at clinical presentations, patient expectations, and once again go over the anatomy from a radiological perspective. So starting with presentation, how does the patient present to you? And what we have done is to divide this into what we call hard symptoms and soft symptoms. So in hard symptoms, is it unilateral? Is there facial pain? Is there mucopurulent discharge, hyposmia, and nasal obstruction? These are all come into hard symptoms or symptoms with far more significance than soft symptoms. In soft symptoms will come if the presentation is bilateral or there's a generalized headache, patient not sure where it's paining, there's a catarrh, runny nose, and or a post-nasal drip. So these are symptoms that may or may not have any consequence or bearing based on the actual sinusitis or sinus problems, and may occur even in allergy or non-surgical situations. Similarly, when we come to examination, hard findings are ones that are surgically significant and which we expect to get a better result. Whereas soft findings are the patients in whom we cannot predict whether the patients will do well or not well. So in hard findings, we'll have once again, if findings are unilateral, if there is gross polyp or polyposis, if there's a very significant deviated septum, and or you're seeing mucopus in the nose. As against this, the soft findings will also contain contact zones. Mucosal contact zones has been much talked about and discussed, and what we feel that often patients even in normal situations will have some amount of mucosal contact zones and therefore may not be as significant as one has thought in the past. Once again, concha bullosas or inferior turbinate hypertrophies may or may not be significant. Uncinate abnormalities, is it a hypoplastic, is it lateralization, mineralization, and is there just mucus or is there serous discharge in the nose? So what we need to do really is to take the examination findings with the presentation findings, enumerate all the hard findings as against those of soft findings, combine it with a diagnostic nasal endoscopy. Now when we do a diagnostic nasal endoscopy, we'll add to our examination findings. And we put all these together, and those patients that have a higher score in the hard symptoms or the hard findings will basically be patients who are expected to do far better in surgery as compared to those patients who have a higher soft findings or soft examination score, in whom we are not so sure how the surgery will go. Let us look at how a diagnostic nasal endoscopy can add information or add value to our examination findings. And this is a perfect situation where we did a diagnostic nasal endoscopy on a patient that had apparently normal nasal examination using a 30-count speculum on anterior rhinoscopy. So on the left side, inferior turbinate, floor of the nose, and a little polypoidal inferior end of the turbinate going into the nasopharynx. You see the eustachian tube opening laterally, the tubal eminence, the uvular bulge, and the rest of the nasopharynx. As we come out from the nasopharynx, we see the posterior end of the middle turbinate and what looks like a perfectly normal middle meatus. However, on closer examination, when you put a suction in there, you saw a lot of mucus that came out of the accessory ostium, which had been occluded by this polyp stuck onto the lateral wall and which was sort of obstructing the normal outflow from the maxillary sinus. In addition to this polyp in the middle meatus, there was another polyp in the, which some of you might have noticed earlier, in the superior meatus between the middle turbinate and the septum, now coming into view, which again would have gone completely unnoticed in a normal examination. So now what would have essentially been soft findings are converted into hard findings. And at the end of it, we would have a system by which we would have a patient rating score giving more emphasis to hard findings or hard examination findings or symptoms as compared to soft findings. And patients with a higher rating score are more likely to benefit from surgery as against those with a low rating score. So what are the patients that we would choose to operate, or when would you think we need endoscopic sinus surgery? The common indications, of course, include chronic sinusitis, sinonasal polyposis, allergic fungal sinusitis or eosinophilic mucin, mucoceles and pyoceles of the paranasal sinuses, in a large number of fungal sinusitis in which there is no bony involvement or extra sinus involvement. Sphenoid pathology, of course, the endoscope is absolutely phenomenal in detecting and controlling epistaxis. Occasionally in sinusitis, when there is a threatened complication, it is excellent for a limited endoscopy, especially when you have things like a septal spur, in dealing with pneumatizations of the middle turbinate, and sometimes as an adjuvant therapy in asthma, cystic fibrosis, or patients with AIDS. Again, in persons who are frequently exposed to pressure changes, whether you're pilots or divers, and endoscopic sinus surgery is very useful to prevent barotrauma. Children or sometimes in adults with foreign bodies or rhinoliths, the scope provides a very easy means of treating these patients. Which brings us to an extremely important slide. What does the patient expect from this surgery, and what should your informed consent contain? What kind of information should you give the patient? So the frequent questions that the patient will ask you is, what are the results of FESS? Is there a cure? And the answer to that is no, because this is not an excisional surgery. It's not like an appendix or a tonsil which you take out, throw away, and then the organ is no longer there, so you will not have a problem. In sinus surgery, the sinuses being part of your skeletal framework, the only thing that is done is they are opened up. The disease is cleared, but they're not excised. So yes, you will have benefit, but not necessarily a cure. So you're not going to become Superman and never have a sinus attack in your life. Will there be a recurrence of disease? Yes, in sinusitis you may have occasional episodes of a bad cold or an allergic sinusitis or viral infection, but the benefit is that these normally pass off easily. Like in any normal person, they come and they go. They should not become chronic or long lasting, and so the symptoms of obstruction and discharge and headache should all be significantly relieved. The question of recurrence occurs especially in polyposis. Polyposis are notorious, and allergic fungal sinusitis are notorious for recurrence. You leave behind one polyp or leave behind 2 millimeters of allergic mucin, you can have a recurrence. One, of course, the technique of surgery is important. How you operate, how much of disease you can remove, how much of it you've left behind. That will dictate the recurrence. Second, the kind of adjuvant therapy that you give, whether it's steroids or antibiotics or antifungal, which is also as important as the surgery. And three is the inherent nature of the disease. Some patients with polyps are basically more aggressive as compared to other patients and tend to recur despite your best efforts. So I think patients must be aware, especially in polyposis, that there is a risk of recurrence, and we do our best to ensure that the patient remains symptom free, if not necessarily disease free. As far as obstruction goes, surgery is very good, and most situations where there is obstruction, unless there is a recurrence of polyposis, will remain free of obstruction. As far as anosmia goes, and this is a difficult situation to handle, patients with complete anosmia, whether it be polyposis or nasal mass, we generally don't promise them anything. We say if you get your smell back, it's a bonus. Patients, on the other hand, who have hyposmia are more likely to recover their olfaction as compared to those with no smell. However, you need to be guarded when assuring the patient of return of smell, because we don't know really how much disease you can remove, how much you leave behind in the olfactory groove, and you certainly don't want to use a debrider or any mutilating surgery in that area. Once again, you must remember that allergy is not treated by surgery. No surgical intervention is going to relieve the patient of sneezing or watery discharge. and those symptoms related to allergy will remain even if they are relieved for a short duration post-surgery. They will certainly come back. So the patients will be on adjuvant medical therapy. Polyposis and AFS, we have discussed, is an extremely difficult situation to tackle. You have to be well skilled in your surgery to ensure that you have as much excision of disease as possible before you can think of avoiding recurrence. In patients with revision surgery, again, the situation is more difficult. Like in surgery anywhere else, revision surgery is far more difficult. If you have access to patient notes, surgery notes from the earlier surgery, wonderful, it adds a lot of information. You must have good imaging of the patient before you commit to the patient as to how much time the operation will take, how simple the operation is, and how much pathology is existing. Again, from your side, whenever you operate, extremely important that you write your operation notes well, so that if the patient has a recurrence and goes to another surgeon, it will help that surgeon in doing a better surgery and potentially avoiding a complication. So, informed consent, there are a vast number of complications that may occur with sinus surgery, and the more we tend to go into the sinuses and do advanced surgery with the endoscope, the greater the risk of complications, essentially being bleeding, blindness and meningitis because of a CSF leak. When you have complications that are potentially life-threatening as against the disease, which is affecting quality of life but is not life-threatening, it's a little difficult to sometimes explain to the patient that yes, these are possibilities. If the patient asks you pointedly, will my eye be affected, or what are the complications, I think you have to inform the patient what all the complications are. If the disease is of a nature where again your chance of complication is high, once again, whether it's fungal sinusitis or a mass, nasal mass, there's erosion of the lamina, then again you must inform the patient what the potential complications of this procedure are. If you're doing a very limited, simple sinus surgery, anterior group of sinuses, and you don't expect them to hit the optic nerve or go into the sphenoid and have torrential bleeding, then of course you can tell the patient about the regular complications, some post-op bleeding, the crusting, post-op problems, and only inform him about the more serious complications if the patient desires to know, or if the pathology such indicates that it may be better to tell the patient. It's always better that the patient is informed as far as possible and takes his own decision. Because if there is a complication, then the patient should have been advised beforehand. Finally, you have to tell the patient that of course if there is a complication, whether you are capable of handling it or not handling it, and the potential for having a complication if you don't operate. So there will be certain diseases like fungal sinusitis which will create the complication if you don't operate, in which case it is probably a lot safer to have operated than not to have operated. So we come next to pre-op preparation, and what will then be our choice of treatment for these patients. So almost all of our patients, and we're talking basically of sinusitis and polyposis patients being the bulk, the commonmost group of our patients, these patients have received antibiotics, maybe a number of courses, but as a pre-op preparation will again receive a course of suitable antibiotic, whichever works well in your practice, at least for 5 days prior to surgery. On the day of surgery, they will get an IV shot. You will also get decongestants and mucolytics. There is a large tendency to prescribe antihistamines to all patients with sinusitis and polyposis. The reason that we have mentioned antihistamines on this slide is that I prefer personally not to give antihistamines, because we have found that antihistamines tend to thicken the mucus, and this actually causes in further obstruction and aggravating the symptoms of sinusitis as against relieving it. We also know from experience that antihistamines and polyposis does not work. The only thing that works is steroids. So then we need to give, in polyposis especially, steroids. And typically we give a course of about 2 weeks of oral steroids, starting from 40 milligrams OD and cutting it down over 2 weeks. These patients will also receive nasal steroid spray, and the choice is usually between fluticasone and cyclosamide now, which is new and seems to be giving us good results. The other thing which is also equally important are decongestant local drops, whether it's metazoline or oxymetazoline. We would tend to use it a few days at least prior to surgery to have as much decongestion as possible, and again just before surgery, before we take the patient into the theatre. Steroid local drops are used by lots of people and sometimes give good results with polyposis. Personally, I prefer, if I am giving steroids orally, not to use local steroid drops. To continue with patient pre-op preparation, there is a controversial subject which is antifungal drugs, and unless there is frank allergic fungal sinusitis, we then decide not to give antifungal. And only in those patients who have frank antifungal, I will use itraconazole twice a day, 100 milligrams as a pre-op thing, and it's extensive fungal, even up to 200 milligrams twice a day as a pre-op preparation in the 2 weeks along with steroids. If the patient has an invasive fungal sinusitis on the other hand, then of course you're looking at amphotericin B and in an IV format. Again, a lot of research has been done in leukotrienes and the effect or the role of anti-leukotriene agents. The top of the list is montelukast, and one feels that especially when you're thinking of interleukin 8 levels being high, then montelukast once a day as a pre-op preparation would probably be useful as an anti-inflammatory, as an inflammatory mediator drug to reduce the mediators of the anti-inflammation agents, to bring that down. And we feel that there might be a role of montelukast as a pre-operative preparation, and this is a study that we are doing, and at this moment I can't say that we have enough experience to tell you whether it's useful or not useful. A lot of work has come out of Japan where they've used macrolides, especially roxithromycin, for long periods of time, again as an anti-inflammatory agent, and we tend to use it maybe more in the post-operative phase, but sometimes along with steroids in the pre-operative phase. Right, so coming back now to anatomy. In any surgery, anatomy is really the essence of what your surgery is going to be about, how you're going to approach surgery, how you're going to plan surgery, what the pathology has done, and how you will therefore tackle the situation. In this area, anatomy is even more crucial because you're surrounded by vital structures. You have the brain upstairs, you have the eyes laterally, and you have the internal carotid and the cavernous sinus, and a very important vasculature posteriorly, and therefore your examination has to be collaborated by radiology, and only when you put both together will you really have a complete three-dimensional understanding of anatomy in this area, which will really be your road map, your guide to performing the surgery. The gold standard for radiology in PNS is CT-PNS, and the CT scan of the paranasal sinuses would in our hands include both bone windows and soft tissue windows in all three views, coronal, sagittal and axial. And there is a great tendency all across the board, all through India, where we tend to do limited PNS cuts. And I'm a very strong proponent against this, because I feel you're going to lose a tremendous amount of information by having one single film of only a few coronal sections, bone window and nothing else. All your allergic fungal sinusitis, your soft tissue is far better seen on soft tissue windows. Your axial and your sagittal scans add so much information to frontal sinus surgery, to frontal recess area and the posterior ethmoids, that without it one doesn't really have or appreciate a three-dimensional view of what anatomy is going to be. Again, it should not be very wide cuts. We normally use 2 to 3 millimeter cuts to have as much access to detail of anatomy as possible. What we must remember is that the coronal should be a true coronal, which is in a plane perpendicular to the heart phalanx. There will also be certain situations where you want to do an MRI. What are those situations? When you have tumors, when there is fluid, whether it's cystic or acute, when you want to see the vasculature in relation to pathology, or any complication of a sinus problem, is when you're going to look at MRI. So let's start with CT scan. What are the things you're going to look at in a CT scan? Initially, you're going to start off with looking at the agar nasa and the frontal cells. The relation of the agar and the frontal cells to each other, their relation to the frontal drainage pathway. Because this will really form the most difficult part of your endoscopic sinus surgery as far as I'm concerned. And unless you know the exact anatomy in this area and the way the frontal drains into the nose, you're going to be sort of poking in the blind, not find the frontal sinus, or worse yet, create an iatrogenic CSF leak. We're looking at the lamina papyracea and seeing if there's any erosion of the lamina papyracea because of disease. We're looking at the anterior ethmoid artery and seeing if there's a low-lying anterior ethmoid artery. Is it likely to come in your field? Are you likely to cause trauma to it? Is it nicely against the skull base? The cribriform plate, and you're going to see if there's a type 1, type 2, or type 3 according to Quiroz classification. And that again will tell you whether you need to stay away from it or is it relatively safer to be going a little medially. The posterior ethmoid structure, you're looking at the relationship to the optic nerve, and in that context the Onodi cells become important. And finally, in the sphenoid, you want to see relation to the intersphenoid septum, the way it deviates, and where does it end up? Does it end up on the optic nerve? Does it end up on the carotid? Or does it end up harmlessly? How much of it can you remove? What about the carotid? Is it bulging into the sphenoid sinus, or is there a bare optic nerve running right through the sphenoid? So these are all the very important aspects that you're going to study on the CT scan. Apart from this, of course, you're going to be looking at the ethmoid sinus, how many cells there are, the crown lamella, the maxilla, the middle turbinate, all the other structures that you need to know when you do endoscopic sinus surgery. So this is an example of a CT scan coronal, and just to show you very roughly the anatomy. You have large concha bullosas on both sides. You have the orbit laterally. You have the nasolacrimal duct over here, which will then open into the inferior meatus. You have quite a strong septal spur going into the right side and touching the inferior turbinate. You have the frontal recess, you have the crista galli, and you have the cribriform plates. So here you have the medial cribriform, and then you have the lateral cribriform. And you can see here that here is a shallow lateral cribriform, so we call it a type 1 Quiroz, where it's less than 4 millimeters, and then a type 2 Quiroz would be 4 to 7 millimeters in height, and that would be a type 2 Quiroz. And if it's a type 3, which is still higher, then you have a large thin height of plate, and it's certainly important then to stay away from it. So now what I'm going to do is to take you through a series of plates to show you how we would read or interpret a CT scan, and why it is important to go section by section to try and understand the anatomy and plan your surgery so that it's safe for the patient, it's relatively atraumatic, and you achieve what you have decided to achieve before surgery. So let's start with the right side. So here you can see the frontal sinus and a small type 3 frontal cell. When you go to the next cut, you can see that cell becoming larger, the rest of the frontal sinus above it. The third cut shows us now a still larger frontal cell and just the start of a small lateral cell with the frontal sinus above. At this moment, we still have no nasal anatomy to be seen. We are still very anterior. The next cut in the middle row, the first cut, shows us now that the type 3 cells in the frontal with the last bit of the frontal sinus above. And when we go to the middle cut, we see how these cells have developed, and we also see the nasolacrimal sac. In the nose itself, in the next cut we will see the agar nasi cell, which seems to be almost in continuation with the lateral type 3 cell. The medial cell here seems to be coming to an end, and you have the start of the middle turbinate. You also have the start of the maxillary sinus on the right side, and you can now see a more prominent bulge of the inferior turbinate. The bottom row, the first cut, shows us the maxillary sinus, inferior turbinate. The middle turbinate has now become more obvious. You see the agar and the end of the type 3 cell here, and the end of the frontal recess. The next cut shows us the nasolacrimal duct, the uncinate process, early pneumatization of the middle turbinate. You see also the cribriform plate, the medial cribriform and the lateral cribriform plate, the end of the frontal recess, and the start of the ethmoid sinuses. The final plate on this slide shows us again the maxillary sinus now developing well with some soft tissue in it, inferior turbinate, the uncinate process which is attached to the ethmoid bulla, a concha bullosa of the middle turbinate, and again the medial and the lateral cribriform plates. Above that is the fovea ethmoidalis. Just below that, coming out of the lamina papyracea as a funnel, you see the exit of the anterior ethmoid artery on this side. Okay, so now we go to the left side. On the left side you see a large frontal sinus. See the frontal sinus continuing, almost seems to be going across the midline here. Similar situation on the third slide. When we go now to the first slide of the middle row, we see that that medial part has now become an interfrontal septal sinus cell, and the frontal sinus itself is more lateral. Further down the middle row, you see the frontal sinus is now draining or would drain laterally. You have the interfrontal septal sinus cell here, and again you have the start of the middle turbinate. Nasal septum looks reasonably straight. The final film on the middle row shows us the frontal recess and where the frontal sinus would drain in. You see the interfrontal septal sinus cell now coming down and having what is apparently a separate drainage pathway medially as against the superior connection to the frontal sinus anteriorly. You also see formation of the middle turbinate much better, and you see the agar nasi now well defined with a type 1 frontal sinus cell. You see the start of the maxillary sinus and again the lacrimal sac on the left side. First film on the last row shows the end of that interfrontal septal sinus cell. You see the end of the frontal sinus, the frontal recess here, and you also see the maxillary sinus on the left and a little bit of the start of the ethmoid bulla. The middle row shows the ethmoid bulla now developing well. You see the turbinate with early pneumatization of the middle turbinate on the left side as well, and you see the end of the frontal recess on the left side, and on the next cut again, like we saw on the right, you see the funneling of the anterior ethmoid artery to indicate its exit point. See a small concha bullosa. The ethmoid bulla is now well developed on this side, and the lamina papyracea appears intact. You have the inferior turbinate here and a well-formed maxillary sinus with the infraorbital nerve. Right, so let's go to now the posterior group of CT scans of the same patient. So we see now we're going to continue with the right side. The middle turbinate, concha bullosa, the last part of it, the inferior turbinate, and the uncinate process which would attach and run along the ethmoid bulla. This is now a well-formed ethmoid bulla, and you see of course the septum with the medial and the lateral cribriform plates, the maxillary sinus with the infraorbital nerve on the right side. If you come to the next cut now, you see that the middle turbinate is starting to turn laterally, and you have then the start of the posterior ethmoid group of cells. You also see the start of the superior turbinate, indicating that that's the superior meatus. You have the maxillary sinus again and the inferior turbinate. The next cut shows us that the middle turbinate has now turned laterally to attach to the orbit, forming the horizontal part of the ground lamella. The posterior ethmoid cells are now well formed. Here you have two cells well seen. You also see a funneling from the orbit, indicating the posterior ethmoid artery exiting from the lamina papyracea, and you see the maxillary sinus. The second row, the first film, you see again the maxillary sinus with the posterior fontanelle and probably an accessory ostium out there. You see 1, 2 and now a small third posterior ethmoid cell as well, and you see the orbit that's getting consequently smaller in size. The next cut shows us again the end of now the posterior ethmoid sinuses on the right side, middle turbinate, little bit of soft tissue here, and the maxillary sinus. And this would now be the final cut of the posterior ethmoid cells, showing a large posterior ethmoid sinus and the start of the sphenoid sinus from an inferomedial position as compared to the posterior ethmoid cells. You see the posterior part of the maxillary sinus, and you see the middle turbinate has now become a lot smaller, and the superior turbinate also, you see the ground lamella in a horizontal position. Also, you need to note that the roof of the posterior ethmoid seems flat or a little concave as compared to the next cut, where the roof seems a little more convex, indicating the sphenoid sinus is now starting or started. So this is now the sphenoid sinus, a small remnant of the posterior ethmoid above it in relation to the optic nerve, indicating that there may be a small onode cell on the right side. You see the intersphenoid septum deviating slightly towards the right side and probably ending up on the optic nerve on the right side, and the posterior part of the septum as well as the turbinates. Our last view of the CT scan on the right side shows us the sphenoid sinus. You also see the Vidian and V2 indentations on the scan, and you see now the choana of the right side. If we turn our attention now to the left side, we see once again the orbit with the lamina papyracea. You see the ethmoid bulla well formed here, the last bit of the pneumatization of the middle turbinate, and the posterior lateral cribriform plate. The next cut shows us how the middle turbinate from the coronal attachment starts turning laterally, so that you now have the start of the posterior ethmoid above it. You have the superior turbinate coming into view, and this would then be the superior meatus. You have the ethmoid bulla here, you have the lamina papyracea, and of course the maxillary sinus. Our next cut shows the middle turbinate is now turned completely horizontal and attaching laterally to form the ground lamella horizontal part, and again you have a large medial posterior cell and a smaller lateral cell. The maxillary sinus contains a little fluid, and on the next scan again you see how the orbit is becoming smaller. You see the larger posterior ethmoid cell medially and the smaller cell laterally, the posterior part of the middle turbinate and the inferior turbinates. The next cut shows us tending towards the end of the posterior ethmoid, the maxilla and the orbit. And again, as we come towards the end of the posterior ethmoids, we once again note how the sphenoid is going to start developing in this area, and this is seen even better on the next cut. You even see the superior turbinate has now turned and formed the ground lamella of the superior turbinate. So this is now the start of the sphenoid, and you have a much larger onode cell on the left side in relation to the optic nerve and sitting above the sphenoid sinus on the left side. And this is now the end of the sphenoid on the left side. So we could now go towards the axial cuts on the next film. Right, so coming to the axial cuts now, let's look at both sides together, starting from superior and going all the way down to inferior. So superior most, you have the two frontal sinuses on the left and on the right with the intracranial cavity here. On the next cut, you see the left frontal sinus draining laterally. You have a small septation anteriorly. You have the interfrontal septal sinus cell lying medially, which would then drain medially. And you have the agar cell here. You also have a suprabular cell in this area on the left side and the posterior ethmoid cells on the left side. On the right side you have the posterior ethmoid cell here, and you have the frontal sinus here with the two type 3 cells, and you have then the agar cell here with a small pneumatization superiorly of the anterior ethmoids. As we go further back or further below, we see now the sphenoid sinus on both sides. You see the end of the posterior ethmoids on this side, and you also know the relation of the optic nerve to the posterior ethmoids and the sphenoid sinuses. You see the ethmoid sinuses and the ground lamella on both sides, the ethmoid sinuses and the nasal septum. You also see the relation of the ethmoids to the lamina papyracea and the orbits. As we go still lower down, you now see the start of the maxillary sinus coming into view on both sides. We have now gone below the level of the sphenoids. This would be the end of the sphenoids on both sides, opening into the sphenoethmoidal recess, but of course on a more superior level over here. You see the inferior part of the ethmoid sinuses on both sides. You see a pneumatized middle turbinate seen better on a cut which is still below, showing the inferior part of the middle turbinate pneumatized well, and you see the maxillary sinuses on both sides. You also notice on the next cut now the maxillary sinus being very well defined with the pterygoid plates. And what you really appreciate are the walls of the maxillary sinus, the posterior lateral and the anterior walls especially, which are seen very well on axial cuts, along with the posterior ethmoids and the drainage pattern of the frontal sinuses. These scans are also good to tell us the relation of the frontal sinus to the interfrontal septal sinus cell and the frontal cells. We are also seeing the eustachian tube opening laterally and the fossa of Rosenmuller on a more medial plane in the nasopharynx and the choana in these areas. So the inferior most axial cuts here showing the lower part of the maxilla. So again, to repeat, the axial cuts are important for us from a frontal sinus perspective, frontal sinus drainage pathway perspective, posterior ethmoid cells and the relationship to the optic nerves, especially important in orbital trauma when you're looking at an optic nerve decompression, and also to study the relationships of the walls of the maxilla and the pterygopalatine fossa if you're doing tumors like angiofibroma. And now lastly we will go to the sagittal scans. So we're going to end our study of the CT scans of this patient by looking at the sagittal scans, and we're going to start on the right side. So you see the orbit, you see the lateralmost part of the frontal sinus superiorly and the maxillary sinus inferior to the orbit. On the next scan you see now of course still the frontal sinus, you see the orbit progressing and the maxillary sinus here. As we start coming a little more medially, you would see the frontal sinus, you may see a part of the supraorbital cell, or you may see parts of the type 3 cell if they so exist in your patient. As we come further medially, we're on the right side, you see the type 3 cell there, you see the orientation of the roof of the ethmoid sinuses, you see the anterior group of the ethmoid sinuses, you see the ground lamella, and you see the posterior ethmoid sinuses over here. And you also see a little bit of the agar nasa, but that is seen better now in the next cut where you see the agar nasi in continuity with the type 3 cells. So you have the two cells, and you would realize now that these type 3 cells are almost in contact with the skull base, and to enter into the frontal sinus, as we also saw from the coronal, one would have to enter either through the roof of one of these two type 3 cells. You have the ethmoid sinuses here, you have a small infrabullar cell here, and you have the large posterior ethmoid cells over here. And you'll see that it's in contact with the optic nerve as well. You have the sphenoid sinus in the inferior part. So this is how we would study the sagittal scans, looking at Onodi cells, looking at the sphenoid pneumatization. Is it conchal pneumatization? Is it a cellular pneumatization? So the suprabullar cell, the infrabullar cells, and also the drainage into the frontal recess, and how one would approach it as we would in a regular FESS. Coming to the left side, we notice that this is the left side, that you have the interfrontal septal sinus cell, the frontal sinus, and the architecture of the ethmoid cells. This is the cella. And in the more lateral cut, you see a larger posterior ethmoid cell forming a large Onodi cell. You see the optic nerve here, and a much smaller sphenoid cell. And more lateral cuts, of course, would then establish the relationship of the drainage on the left side, but we've done that on the right side. So the essence of doing all these three scans is to put them all together, and using either your own imagination or Wormhole's technique of building blocks to reconstruct either on paper or in your mind a complete 3D picture of what each cell looks like, starting from the frontal to the frontal cells, to the bulla, to the suprabullar cells, posterior ethmoid, and the sphenoid, so that as you operate, you can not only imagine where the frontal drainage would be, how many cells you need to open up, but you have a much easier, less complicated surgery, and of course a complete removal of disease in a more safe manner. The other thing of importance that I mentioned earlier is soft tissue windows, and these are examples of a patient with soft tissue windows. If you look at the top row, these are all bone windows, and you have complete opacification of the sinuses, you have some bone destruction, you have pushing of the bone, and you can't really be sure, is this polyps, is this fungus, is this tumor? And what really helps you in this situation is a soft window, a soft tissue window, which is the bottom row, which very clearly demonstrates a double density, very classical of allergic fungal sinusitis. And you know now, by having this added information, that you need to give this patient 2 weeks of steroid treatment. All this will shrink, and you will have a much easier operative session, because now you have less disease because of the effect of steroids. Which is why a soft tissue window is important to differentiate one pathology from another. You would also know that in the maxilla, a lot of it is retained secretion, is retro-obstructive sinusitis, as apart from the ethmoid, which is full of polyps and fungus. The third thing regarding CT scans is when to do the scan. I think when you see a patient with polyposis and you want to impress the patient how much pathology he has, you rush into a CT scan. And fine, look at the top row, extensive polyposis, it shows you a lot of disease, and you say, oh my god, you know, your disease is so bad, you need surgery, and the patient is very concerned that yes, he has so much disease, but how much does it help you in planning your surgery? We have just gone through the scans one by one to see as much bony framework as possible, to see how the cells are, how they end. And here on the top row, you see there's some bony structure here going into the frontal area. You see a lot of bony structures, but you cannot really tell anatomy clearly. This same patient, when we rescanned after 2 weeks of steroids, you now have clearly defined anatomy all through your sinuses. You have less pathology, you have better anatomy, and I think as a surgeon, that should be your goal. Not to see so much pathology, but more to see anatomy. Fair enough, your patient is impressed with the disease, but what will really help the patient is your understanding of the anatomy and therefore doing a good surgery. So we would recommend that you do the scan just before surgery, preferably after your antibiotic in case of sinusitis, or in case of polyposis, a steroid course, and then do the scan. Coming from CT scan to MRI. You're going to do MRI when you have soft tissue, in suspected cases of tumors, when you have large cystic things and you don't know, is this cystic, is this soft tissue, is it solid, how much destruction is there, how much sinusitis is there, how much actual tumor is there, and to differentiate normal from abnormal, then MRI is superbly useful. Any complication involving the orbit or the intracranial area, again to differentiate brain tissue from pathology or orbital tissue from pathology, an MRI is very, very useful. In relation to vasculature, CT scan does not show you vasculature unless you have combined it with contrast studies, but an MRI will show you all the details you need to know about vasculature. Is your internal carotid part of the tumor? Is your anterior ethmoid being pushed by the tumor? Is it running through the tumor or through the polyps for that matter? What is the relationship of your vasculature to the pathology? And this is more important when you're dealing not in our situation with basic FESS, but in more complicated situations when you have pituitary adenomas, meningiomas, things like that to operate. When you need to see nerves and vessels in relation to pathology. Any complication of endoscopics of sinusitis, whether it's endocranial or intraorbital, anything that extends beyond the sinus will be served well by an MRI. So to give you some examples of MRI, these are plates of a sphenoid mucosa, and if you see just the CT scans, the first couple of CT scans, you realize again a bone destroying sort of large lesion extending intracranially, going extremely laterally here, and you're at a complete loss. It's very difficult for us to understand just on this what this pathology is. It could be really anything going lateral to the orbits you see here. But when you do an MRI, you see it's a nice fluid-filled, smooth, extradural pathology. And then, if you look at the axial and the sagittal, it takes you really no time to realize that all this is in continuity, starting from the sphenoid, and this is just a sphenoid mucosal, which is easily tackleable by an endoscopic approach, as compared to ending up doing some extended transcranial approach. So really, in these sort of situations, to have an MRI was extremely useful. Other such situations are some of these, where you have a break here, and you're not sure again if this tumor or if it's a meningocele or an encephalocele, and quite clearly the next cut, the lower cut, tells you it's more of a meningocele and not even so much a tumor or an encephalocele, but you can see CSF in there occupying most of it, and so it's largely a meningocele with just a little bit of solid tissue. Again, the second film demonstrates deficiencies in the bone here, and you see some soft tissue coming in the nose, probably a tumor. But the MRI clearly delineates a meningioma with a large transcranial part. And so this patient would require a transcranial approach, maybe assisted by an endoscopic removal of the end of the nasal part. Another example is a fungal granuloma, which on a CT scan would look relatively normal. The enhancement of the meninges is picked up very well by MRI. And as a final example, we have a patient with an extradural abscess extending from the sphenoid sinus and forming an extradural abscess here with clearly well-defined ring enhancement, again seen very well on the MRI. And these are the reasons why it is important not to forget that you have options to different modalities. And when we talk of sinus surgery, we are looking essentially at CT scan. At basic endoscopic sinus surgery, CT scan. But if a patient has a complication or an advanced pathology, then of course you need to consider an MRI. And that brings us to the end of CD2. Thank you.